Yeah, good afternoon, everyone. Today we will have a brief discussion on assessment of regional ventricular function by transesophageal echocardiography. And to start with, we will have some blood anatomy of coronary circulation. There is a left coronary circulation supplied by the left anterior descending artery and left circumflex artery arising from left coronary cusp. The major branches of the LAD are septal perforators, which supplies the anterior two-thirds of the septum, and there are diagonal branches. Circumflex artery supplies gives rise to obtuse of marginal branches and posterior interventricular branches or posterior descending artery in 10 to 15% of the cases, thus giving left dominance. Right coronary circulation is given by the right coronary artery. It courses between the right atrioventricular grooves and give rise to the conal branches, the branch to the SA node in 60% of the cases, and AV nodal branches, and then it give rise to marginal branches, which are termed as acute marginal branches. Papillary muscles are supplied. Anterolateral papillary muscle is supplied by OM, branch of the obtuse marginal branch of left circumflex, and diagonal branches of LAD. It is supplied by two arteries, whereas posterior medial papillary muscle is supplied by either RCA or LCX, depending on the dominance of the coronary circulation. Now, this is a pictorial depiction of the fluid distribution of the coronary. The anterior surface is majorly supplied by the left coronary circulation through LAD and marginal branches, whereas the left posterior surface is supplied by the tributaries branches of the circumflex artery, and right posterior surface is supplied majorly by the posterior left ventricular branch of the right RCA, right coronary artery. Now, to understand the regional function of the LV or the myocardial perfusion, LV is divided into three equal parts along the long axis of the heart. The three short axis slices of LV are basal 1/3, which is from mitral annulus to the tip of the papillary muscles. Then there is a mid cavity 1/3 part, which is along the entire length of the papillary muscle, and then there is an apical 1/3, which is the area beyond the papillary muscle to just before the cavity of LV ends. Then there is an apical cap, which is the area of LV myocardium beyond the LV cavity. It is just a chunk of myocardium. The 17 segment model is the most widely accepted model for analyzing the LV segmentally. This is a pictorial depiction of the 17 segment model of the LV. It's a bull's eye plot of the segments and coronary arteries territory. The basal segments, which constitute 6 segments, constitute 35% of the myocardium. Then there is a mid-cavity segments, which are also 6 segments, which constitutes another 35% of the LV myocardium. And then there is a apical segments, which are 4, which constitutes 30% of the LV myocardium. Starting from the outer part, it is a left anterior, basal anterior. Then there is a basal anterolateral going clockwise, and then there is a basal infrolateral. Then there is a basal inferior, and basal infroseptal, and basal anteroseptal. Yeah, the mid circle. Then there is inside the outer basal segment, there is a mid cavity segments, which are going clockwise. It is a basal anterior, mid anterior, then mid anterolateral, then mid infrolateral, mid inferior. Then there is a mid infroseptal, then there is a mid anteroseptal, and again a mid anterior. Now the innermost is the apical segments, which are 4, which are clockwise, going clockwise. It is apical anterior, apical lateral, apical inferior, and apical septal. The centermost is apical cap, which is a apical myocardium. Now, identifying the myocardial segments. When using the transesophageal echocardiography to evaluate the regional ventricular function, one has to attempt to make the inferences about 3D structure from a 2D images. Hence, multiple images from multiple planes must be acquired, and assumptions must be made about the shape of the ventricle and coronary artery distribution within the ventricle. There is a tremendous variability in the coronary blood supply, but one need to assign individual segment to specific coronary artery territory to facilitate the localization of ischemia and guide the management. Now, to identify the affected myocardial segment, the commonly used views are the mid-esophageal 4-chamber view, mid-esophageal 2-chamber view, mid-esophageal long axis view, and transgastric basal short axis view and mid-papillary view. In mid-esophageal 4-chamber view, one is able to see the infroseptal and the anterolateral walls of the LV and the apical segment. In mid-esophageal 2-chamber view, one is able to see the inferior wall and the anterior wall of the LV. In the mid-esophageal long axis view, that is 120 degree, one will be able to see infralateral and anteroseptal wall of the LV. Now this is a transgastric basal short axis view in which almost you can see the segments supplied by all the three major coronary territories. Now this is a cylindrical view of the LV in which the plane is divided orthogonally. So in mid-esophageal 4-chamber view, when you are seeing infroseptal wall, opposite to that you will see a anterolateral wall. Okay. Now in mid-esophageal 4-chamber view, as discussed earlier, we will be able to see infroseptal wall. We will be supplied majorly by the left anterior descending artery, and anterolateral wall which is supplied majorly by the circumflex artery. In mid-esophageal 2-chamber view, in 90 degree view, we will have an inferior wall of the LV which is supplied majorly by the right coronary artery, and anterior wall is red in color which is supplied majorly by the left anterior descending artery. Then there is a mid-esophageal long axis view at 120 degree. We will be seeing infralateral wall which is supplied majorly by the circumflex artery, and anteroseptal wall which is red in color, it is supplied majorly by the left anterior descending artery. The transgastric mid-esophageal short axis view, transgastric mid-short axis view, mid-cavity short axis view is the most preferred mode, because in this you will have segments which are supplied by all the three major coronary arteries. Hence any RWMA is easily identified in this view. Still, one will be missing 1/3 of the RWMS if only this view is analyzed. Hence, the regional wall motion abnormality has to be analyzed in all the views. Now, the qualitative analysis of the normal segmental function is done by two major parameters: radial displacement and the endocardial thickening. Radial displacement, also called as endocardial excursion, it is the inward movement of any point on the endocardium with inch contractions towards the center of the LV. Normal radial displacement is more than 30%. Another parameter, qualitative parameter, is endocardial thickening. In endocardial thickening, there will be increased distance between the endocardial and the epicardial interfaces. The decreased thickening is more specific for ischemia, and it is not affected by the cardiac rotation and translation motion. While assessing the regional wall motion, one will encounter two major artifacts which needs to be bear in mind. One is foreshortening, another is pseudo-thickening. Foreshortening occurs when the imaging plane is not correctly aligned along the axis of the chamber being examined. So it creates an image which is shorter than the true length. It most commonly occurs at the LV apex. Pseudo-thickening occurs when the heart moves from side to side through the imaging plane, thus creating an illusion of change in wall thickness. Hence, imaging plane must be perpendicular to the region of LV being examined to accurately assess the wall motion and the thickness. This is the pictorial depiction of the pseudo-thickening. How if the heart moves from side to side, one will be having a false impression of increase in thickness of the LV wall. Now, the qualitative analysis of regional function is done through visual assessment of the myocardial thickening and endocardial excursion, which is called radial shortening of a segment. The score is given as normal, or a normal function is given as 1 score, in which there is a radial displacement of more than 30% and a normal thickening of the myocardium occurs. The score is given as 2 when there is a mild hypokinesia, when the radial displacement is less than 30% but more than 10%, between 10 to 30%, and myocardial thickening is present. The score is given as 2 when there is a severe hypokinesia, when the radial displacement is less than 10% and myocardial thickening is negligible. The score is given as 3, 4 when there is akinesia, when there is a radial displacement of 0% and thickening is absent. Dyskinesia is when there is a systolic lengthening and paradoxical systolic motion. As mentioned earlier, decreased myocardial thickening is more specific indicator of the ischemia, and in extreme cases, there is a systolic thinning can occur. Visual segments even in normal hearts also appears to have reduced wall motion thickening. Now, this is a semi-quantitative method is a regional wall motion score index, which is given as a formula of sum of individual segment score at peak stress or at a rest divided by number of visualized segments. If the wall motion score index is more than or equal to 1, it is considered as abnormal. Now, every regional wall motion abnormality is not always ischemia or infarction. It can be due to some non-ischemic causes like bundle branch block, ventricular pacing, right ventricular pressure or volume overload, and constrictive pericarditis. But the major the causes of interest are ischemia, infection, and hibernation or stunning. Now, tethering effect. Due to tethering effect, there may be an overestimation of the ischemic or the infarcted area by echocardiography due to the attachment of non-contractile tissue that mechanically imparts the contraction of adjacent tissue, which is normally perfused. So, this is the practical application of the viable myocardium, whether it can be hibernating myocardium or it can be stunned myocardium. When the myocardial ischemic insult is severe and prolonged, then it may lead to the myocardial necrosis, which is irreversible damage. If the reperfusion or the relief of ischemia occurs before the necrosis occurs, then it will result in stunned myocardium, which is transient post-ischemic dysfunction. And the recovery of the function takes within days to weeks without any revascularization is not needed in stunning. If there is a chronic low flow, chronic fixed coronary obstruction is there, or if there is a repeated episodes of stunned myocardium, then a metabolic adaptation occurs and it will result in hibernating myocardium, which will have contractile abnormalities and dedifferentiated cells, and it will need revascularization, and the eventual recovery may take weeks to months for a contractile apparatus to reform. Now, assessing the myocardial viability, this is the practical application of regional ventricular function. Viable myocardium is a segment of myocardium that is dysfunctional, that is reduced contractility due to ischemia, but it can be recovered after revascularization. Two pathological states of viable myocardium is there. One is stunned myocardium, another is hibernating myocardium. Now, to assess the viability of the myocardium, the commonly used methods are Doberman stress echo, which has highest specificity, and another is contrast enhanced echocardiography, and then there is a single photon emission computer tomography, in which thallium scan has a highest sensitivity, and fourth is a computer magnetic resonance, cardiac magnetic resonance. Doberman stress echo. It is used to identify jeopardized but viable myocardium, which can be either stunned myocardium or the hibernating myocardium. A viable myocardium is a dysfunctional segment with a reduced contractility that has the potential to improve once the coronary flow is restored. It is of two types, stunned myocardium and hibernating myocardium. Now, there is a biphasic response in hibernating myocardium, in which at low dose of 5 to 7 micron per kg per minute of dobutamine, it will show improved function with worsening of function at a higher dose of 20 micron per kg per minute or more. And it is a hallmark of myocardial viability, and it is the most accurate predictor of functional improvement after revascularization. Now, little bit more difference between stunned and hibernating myocardium is, stunned myocardium is an acute significant reduction of coronary blood flow, whereas hibernating myocardium has a chronic reduction of coronary blood flow reduction. Stunned myocardium is a reversible contractile dysfunction, whereas hibernating myocardium is a ischemic insult, continuing ischemic insult. Stunned myocardium is a viable, but there is no residual ischemia. In stunned myocardium, there is only metabolic changes like calcium overload, neutrophil accumulation, without any significant myocyte structural changes. Whereas in hibernating myocardium, there are a lot of several changes occurs at cellular level, like loss of sarcomere, the loss of sarcomere, sarcoplasmic reticulum disappears, etc. In hibernating myocardium is an adaptive response whereby a myocardium downregulates its metabolic needs to survive the reduced perfusion. Stunned myocardium recovers spontaneously, whereas hibernating myocardium needs revascularization. Stunned myocardium takes days to weeks, within almost 10 days to recover, whereas hibernating myocardium may take weeks to months, up to 6 months to recover. Stunned myocardium shows a uniphasic response to dobutamine stress echo, that is, a sustained improvement in contractility occurs with low dose, and aberrant high doses contractility increases. It becomes more hypercontractile. Whereas in hibernating myocardium, at the low dose of dobutamine, there is increased contractility which worsens at a higher dose of dobutamine. This is more of pathophysiology about viable myocardium. As discussed earlier, there is stunned myocardium recovers spontaneously and revascularization is not needed, whereas hibernating myocardium, revascularization is needed. And it is a it is in hibernating myocardium, there is a continuous ischemic insult, ongoing ischemia is present, whereas stunned myocardium is more of post-ischemic myocardial dysfunction. Now this is a pictorial depiction of the dobutamine stress echo. In normal myocardium, at rest the contractility is normal and it increases at a low dose of dobutamine, and it increases further at a high dose of dobutamine, which is a normal contractile response. In stunned myocardium, at rest the contractility is low, it increases with low dose of dobutamine, it increases further with a high dose of dobutamine, and there is a uniphasic response. In hibernating myocardium, at rest the contractility is reduced, it increases at a low dose of dobutamine, and it worsens again at a high dose of dobutamine, and it is a biphasic response. And it is a hallmark sign for myocardial viability. That is, myocardium is still viable. It can be salvaged through revascularization. Then if there is a severely ischemic myocardium, then the contractility is less at the rest and it does not have any response to dobutamine, and it worsens even at low dose of dobutamine. In scar of myocardium or non-viable myocardium, there is no response to the dobutamine stress test. Now, in emerging RICO techniques for assessing the regional ventricular functions are tissue Doppler imaging, speckle training, and three-dimensional transesophageal echocardiography. In tissue Doppler imaging, the red blood cell Doppler signals are filtered out, leaving only the tissue velocity. It can be displayed either as a pulse wave Doppler signal, or as a color-encoded M mode, or as a 2D color map. In tissue Doppler imaging, high-energy signals generated by wall motion are minimally affected by tissue interfaces. Hence, a high-quality 2D image is always not necessary to obtain adequate tissue Doppler data. Low tissue Doppler imaging velocities correlate well with abnormal myocardial thickening, regional ischemia, and can help to differentiate transmural from non-transmural infarction. However, the limitation of tissue Doppler imaging is, like all the Doppler imaging, all the data are dependent on the angle of interrogation between Doppler beam and the tissue motion. Also, it is susceptible to the cardiac translational motion and myocardial tethering. To overcome these limitations of tissue Doppler imaging, strain and strain rate have been developed, which is strain rate which can be used to differentiate between passive tethering and active thickening of the myocardium. Strain is a change in the length between the myocardial contraction and the relaxation. It is expressed as percentage, whereas strain rate measures the velocity gradient between 2 points, giving the rate of myocardial deformation. Tissue Doppler imaging and strain can be used along with dobutamine stress echo to enhance its accuracy in determining the myocardial viability. Speckle training, it is a quantitative analysis of segmental myocardial function. In speckle tracking, the tracking of unique speckle patterns is created, which are created by scattering, reflection, and interferences of the ultrasound beam within the myocardial tissue. Using the pattern recognition, position of the speckles can be tracked frame by frame throughout the cardiac cycle. Distances between the speckles gives information on myocardial deformation during systole and diastolic events. Speckle tracking can also be used to measure the regional myocardial strain and strain rate. Strain rate done by tissue Doppler imaging or speckle training can be used to differentiate subendocardial infarction from transmural infarction. Three-dimensional echocardiography for regional ventricular function. 2D evaluation is mainly done by eyeballing, and lot of geometric assumptions has to be done for calculation of the volumetric parameters. The recent introduction of three-dimensional TE along with semi-automated endocardial border detection systems allows fast and accurate measurement of the regional ventricular function. Full volume mode is most commonly used in 3D. It is based on mid-esophageal four-chamber view. In it, manually anterior inferior septal and lateral borders are marked, followed by automatic border tracking algorithm. Segmental analysis will display LV shell into 17 segments along with corresponding segmental time volume waveforms. In eye-slice view of the 3D, it displays 9 simultaneously moving short axis views of the LV. Thank you.